This week we are in chapter 13 of your textbook, which covers antidepressants.
So listed here is the criteria for diagnosing a major depressive episode. I'm not going to read the whole slide to you because you can read, but just to give you some of the highlights, these top 3 points are basically, we've talked about anhedonia, depressed mood or loss of interest or pleasure in activities that are normally pleasurable. So that's anhedonia. The next point is that it needs to be a change from baseline, and the final point there is that it needs to be impacting your life, a patient's life in a functional way, whether socially or at their job or at their school, if they're in school. And then in addition, at least 5 of the 9 symptoms listed below need to be present nearly every day. And of course, these are all subjective measurements. Well, significant weight change is not a subjective measurement, but otherwise, everything is pretty subjective and self-reported, so it might be hard to measure. You can read through those criteria. Interestingly, the book points out that older people can show some of those symptoms, such as the insomnia or the change in appetite or things like that. They might feel okay, or not, at least not overly sad, but that type of depression can be treated in the same way with the same medications that we use to treat a major depressive episode as well. The book also points out differences between the sexes, where women are more likely to feel sad or guilty when depressed, and men are more likely to feel tired, irritable. Men are also more likely to turn to alcohol and drugs when they're depressed. And then the final point at the bottom is these symptoms should not be due to something else, whether it's substance abuse or bereavement. If someone's spouse has just passed away, then it makes sense that they would be in a depressed mood, and that it would be a change from the person's baseline, and all of those things would be a normal process, a normal function of the grieving process. So it shouldn't be due to some extenuating circumstance like that. There are a couple different theories of the origins of depression. The monoamine theory is maybe the most popular, or the best known of the theories. The idea here is that depression is a result of dysregulation of neurotransmitters, specifically the monoamine neurotransmitters. Recall that monoamines are the neurotransmitters synthesized from a single amino acid. And most antidepressants available target these neurotransmitters. So there's 3 different systems in your brain. Norepinephrine fibers use norepinephrine as a neurotransmitter. Serotonergic fibers obviously use serotonin. Dopaminergic fibers, recall the VTA, of course, is part of the mesolimbic dopamine system, which we've discussed at length in relation to cravings and reinforcement. So the monoamine theory goes that a decreased amount of one of these neurotransmitters causes a person to get depressed. And the support for this comes from a couple different places. First, if you give a person a drug that increases these neurotransmitters, their mood improves. Things like cocaine and amphetamines release or increase the release of or block the reuptake of these neurotransmitters, and they make a person euphoric. Similarly, in diseases where monoamines are depleted, depression is common, and the book cites Parkinson's as a common disease that goes along with depression, or depression goes along with that disease. However, there's problems with this theory. One I'm calling lag time here, where the medication gets to the brain within hours, certainly within the first day of taking it, and it's producing more of those neurotransmitters. We know the meds have reached the brain based on imaging and neurotransmitter levels in the cerebrospinal fluid, but it's not functional yet. And there's no improvement in depression until a person's been consistent with medication for several weeks.
And then also individual variations, just that tryptophan depletion doesn't necessarily correlate with depression for every person. For some people it does, for some people it doesn't. So there's more to the story than just a decrease in monoamines. There's also a decreased activity, general activity in the serotonin system. And many depressants, as you probably know, are SSRI, selective serotonin reuptake inhibitors. These are kind of the first line antidepressants that are used. So there's decreased 5-HT reuptake transporters in depressed people, possibly because there's fewer serotonin neurons, possibly because of a dysregulation of the entire serotonin system, possibly because the brain's trying to compensate for lower 5-HT. And then there's also decreased binding potential of the 5-HT1A receptors, a specific type of receptor. It might have a decreased ability to bind the postsynaptic receptors, or there's just fewer receptors or they're less sensitive to it. There's fewer neurons altogether. It's not clear if these effects are predisposing a person to depression or if they result from the depression itself. Then there's other theories as well, and the other one that the book goes through in detail is the glucocorticoid theory of depression. So the idea here is that stress plays a role in depression, which is an intuitive thing that you may have already known or been able to postulate. So in figure 13-1, there's an illustration of the hypothalamic pituitary adrenal axis, this HPA axis. And this modulates the fight or flight response. When a person experiences stress, the system begins the fight or flight response using hormones. And so that's useful when we have a threat that we need to run away from or fight against. And normally this gets shut down through negative feedback loops when the stress has passed. So if you look at figure 13-1, you can see the stress crazy bubble lightning thing in the upper left. And it's kicking off this system. The hypothalamus releases CRH, corticotropin releasing hormone, which then causes the pituitary gland to release ACTH, the adrenocorticotropic hormone. And then the adrenal glands release cortisol, which is a stress hormone. So cortisol, you can see, follow its solid line. It's going to go stimulate the prefrontal cortex, the amygdala, and the hippocampus. The amygdala, the fear center of the brain, is going to keep this loop going. It stimulates the hypothalamus, which then you can draw that same loop again. It's going to release CRH, and that's going to release ACTH from the pituitary gland. That'll release more cortisol. But if you follow the dashed lines, you see that cortisol also has the negative feedback loops to shut down production of CRH in the hypothalamus and to shut down production of ACTH in the pituitary gland. Also, when it interacts with the hippocampus and the prefrontal cortex, especially with the hippocampus, their effect on the hypothalamus is inhibitory to shut down the stress response. So that's how this works. In a normal situation, there's this negative feedback loop where signals, basically cortisol, the stress hormone, binding to the glucocorticoid receptors in these different parts of the brain, signals to the hypothalamus to stop releasing corticotropin, releasing hormones. So a person experiencing chronic stress has this response constantly, and their this HPA axis, can be overactive. Maybe it's due to decreased glucocorticoid receptors in the hippocampus. Also in depression, the hippocampus and prefrontal cortex, those parts of the brain that are involved in the negative feedback back on the hypothalamus, those atrophy, they get smaller, and the amygdala gets bigger. So maybe that's what's going on. It's not clear, but the balance is thrown off between the inhibition and the excitation of the stress system. So the constant stress is now the baseline for that person. The HPA axis is overactive. And then the last point here is that these theories are not mutually exclusive. There's examples in the book of how constant stress produces change in the amygdala, and that can upregulate monoamine receptors. The HPA axis stress hormones and 5-HT1A receptors are linked. It's possible that 5-HT transmission is linked to cortisol release. So clearly, our brains are complex, and there's more going on than just a decrease in monoamines or just a dysregulation of glucocorticoid receptors. But those are the two theories of depression that are detailed in your textbook. So there's a couple lists in your book. Table 13-1 and Table 13-2 have lists of different antidepressants. The first generation of antidepressants are monoamine oxidase inhibitors, MAOIs, and tricyclic antidepressants, or TCAs. So first we're going to talk about MAOIs just because they were the first to be developed and the first type to be used. Iproniazide was first used as treatment for tuberculosis. In tuberculosis patients, they just accidentally discovered that it improved their mood. MAOIs, as their name suggests, they inhibit the monoamine oxidase enzyme. This is the enzyme that destroys the monoamines. So you'll remember when neurotransmitters are released into the synaptic cleft, they bind receptors on the postsynaptic cell, and eventually they're released back into the synaptic cleft. And then at that point, the presynaptic cell can take them back, reuptake, or the neurotransmitters can be destroyed. So this enzyme is one one that destroys them. It oxidizes them. So by inhibiting that, monoamine oxidase inhibitors inhibit the destroying, so you're left with more monoamines in the synaptic cleft. These came out of popularity because of negative side effects. There was liver damage with high doses. They were thought to be ineffective, but that turned out it was at too low of doses. So they fell out of favor, but they're still out there, and they're actually considered to be effective and relatively safe still, so they are still being prescribed. Tricyclic antidepressants were also discovered by accident. Imipramine was the first one of them. It was being tested as an antipsychotic, and it was improving people's mood. They're called tricyclic antidepressants because of their chemical structure. They have 3 rings. These are they became more popular because people thought they were safer, but they're not as safe or effective as SSRIs. So this is now the second generation of antidepressants, selective serotonin reuptake inhibitors, or SSRIs. The first of these was Prozac, fluoxetine. It was introduced in the late 80s, and it was revolutionary at the time. It increased the use of antidepressants because it made depression more acceptable. Just the pharmaceutical companies were good at marketing it. And it also made antidepressants more accessible. So these different drugs work differently for different people. They have different side effect profiles. And again, you can see a list of them in Table 13-1. And then finally, the newest ones, or the third generation, are also called atypical antidepressants. You can see this list, or a list of some of them in Table 13-2. And so these are serotonin and norepinephrine reuptake inhibitors. They inhibit the reuptake of these neurotransmitters. So both these and the selective serotonin reuptake inhibitors, it's the same mechanism that I described for monoamine oxidase inhibitors. When the neurotransmitters are in the synaptic cleft, they can either be reuptake inhibitors inhibit the reuptake of them, so they're left in the synaptic cleft for longer. And there appears to be fewer negative side effects of these, but there's always side effects of drugs, so there's always pros and cons to any medication. So now the neurophysiology section, we talked about most of this in the previous slide, but just to cover it again, MAOIs are monoamine oxidase inhibitors. They inhibit monoamine oxidase. which is an enzyme that can destroy or break down monoamines, dopamine, serotonin, and norepinephrine. So that results in increased levels of monoamine neurotransmitters that are available to bind to their receptors. TCAs are tricyclic antidepressants, and they prevent the reuptake of monoamines. So monoamines are not reabsorbed into the presynaptic cell, they're left out in the synaptic cleft. SSRIs are selective serotonin reuptake inhibitors. They block the reuptake of serotonin into the presynaptic cells that had secreted them, so that leaves the serotonin out in the synaptic cleft. And then atypicals, or SNRIs, are exactly the same thing, but they are less selective for just where SSRIs work only on serotonin reuptake. SNRIs can block the reuptake of all the monoamines, or depending on the SNRI, of various monoamines into the presynaptic cell. So that can be a serotonin cell, a norepinephrine cell, or a dopamine cell. So it can block the reuptake of either serotonin, norepinephrine, or dopamine, depending on what the neuron is, what specific type of neuron we're talking about. So the absorption kinetics of TCAs, they typically reach peak blood concentration in a few hours, 1, 2, or 3 hours. That can be up to 8 hours. SSRIs and SNRIs are a little bit slower to be absorbed. They reach peak blood concentration in 4 to 8 hours. Generally, these all have high levels of protein binding. And then alcohol greatly increases the amount absorbed from a specific dose, especially with TCAs. So normally without alcohol present, the digestive system and the liver enzymes destroy a significant amount of an antidepressant before it reaches the bloodstream, so therefore before it reaches the brain. You'll recall this is called first pass metabolism. Alcohol inhibits that first pass metabolism, so then of TCAs, and so then that can lead to an overdose, because when alcohol is present, that first pass metabolism is much slower, so there's a lot more TCA that gets absorbed into the bloodstream. That's because these drugs are formulated with the knowledge that a lot of it's going to be destroyed by first pass metabolism. SSRIs and SNRIs are much less affected by alcohol, so they tend, that's one reason why they're safer than TCAs. Distribution, or where these drugs end up in the body. All of the antidepressants can cross the blood-brain barrier, which is good because they can work in the brain. They also cross the placental barrier and tend to end up, they're concentrated in the lungs, kidneys, liver, and brain. And then depending on the antidepressant, they can also end up in breast milk of lactating women. So the half-lives of these drugs vary quite a bit. The MAOIs have really short half-lives, 2 to 4 hours. Their effect can last a lot longer than this because, especially with the older ones, some of them are irreversible, so the effect on MAO does not go away when the drug's going away, but the newer MAOIs are reversible. So then in that case, with a half-life as short as 2 to 4 hours, several daily doses might be required to keep the drug at a steady state in the body. TCAs have a much longer half-life, up to or around a day, so then they're able to be taken just once a day, which is obviously a lot more convenient than several times a day. And then SSRIs and SNRIs have a lot shorter half-lives than the tricyclics, so they're on the order of 15 to 20 hours. Prozac has a really long half-life, around 4 days. So depending on those half-lives, it can affect how often a drug needs to be taken or how long it takes to get to steady state. The book mentions that Prozac might take up to 75 days for the drug to reach a steady state level in the body. And then SNRIs have a very short half-life, around 5 hours. Again, there's exceptions, some drugs that have significantly longer half-life than that. And then there's a lot of variability from person to person in the metabolism of these drugs due to their genetics. Some people lack some of the enzymes that destroy these drugs, so the drugs stay in their body a lot longer, and it takes a lot longer for them to be metabolized and then excreted. The side effects that come with these drugs can be tough to deal with. So going through them, that MAOIs have a lot of different drug interactions. They potentiate amphetamines, decongestants, drugs that cause the release of norepinephrine. And alcohol and opioids are also potentiated by MAOIs. They cause low blood pressure. They can cause low blood pressure, which can lead to dizziness. And then in addition, the book lists tremors and weight gain. And then also, they can interact with some foods. Tyramine is an amino acid that's found in different foods, aged cheese and beer and wine, chocolate, soy sauce. And normally, tyramine is broken down by monoamine oxidase before it gets into your blood. But when you're taking MAOIs, the monoamine oxidases don't have a chance to break down the tyramine because they're being inhibited. And tyramine can then raise your blood pressure to dangerous levels, and you can risk internal bleeding and stroke. So people on MAOIs have always had to watch their diet. Most of the side effects with TCAs and third-generation drugs are due to their anticholinergic effects, so how they affect acetylcholine. And this is acetylcholine regulates these things: dry mouth, constipation, dizziness, irregular heartbeat. Those side effects listed there are because of these drugs' interactions with acetylcholine. SSRIs are known to be fairly mild with their side effects, but they do have them: nausea, headache, nervousness, insomnia. And then finally, the serotonergic syndrome or serotonin syndrome. This can happen with a bunch of different classes of antidepressants. It's not just the TCAs or just the MAOIs or anything like that. It's characterized by what's listed here: so disorientation, agitation, confusion, fever, shivering, and diarrhea. It can also include extrapyramidal symptoms, which, remember from a few slides ago, these are the Parkinsonian or movement types of side effects, or involuntary muscle movements. They're common with MAOIs, but you can also see this when you're switching from Prozac to other drugs. Because Prozac stays in the body for so long and it has such a long half-life, the level of serotonin goes above the therapeutic levels, and the body just has too much serotonin. So this is insufficient washout time, the time allowed for a drug to be eliminated from the body when a drug is being changed, when you're switching from, specifically in this case, most often when you're switching from Prozac to other antidepressants. So many of these drugs have various effects on sleep. MAOIs can cause either insomnia or drowsiness, sedation in people. And tricyclics also cause sleepiness, drowsiness. They can even be used at times to treat insomnia. High doses of tricyclics can cause nightmares. And then many antidepressants actually change the amount of REM sleep that you can get. So some increase it and some decrease it. And decreasing REM sleep is associated with an improvement in depression symptoms. It's associated with the antidepressant effect of these drugs. REM deprivation, sleep deprivation, and specifically REM deprivation, is known to decrease depression symptoms, which seems counterintuitive at first, but people with major depressive disorders often sleep much more than typical, the 7 or 8 hours that's recommended. So it kind of makes sense. And then SSRIs can cause insomnia in some people as well. And these drugs also can make dreams more vivid. So they can make positive dreams more realistic, but they can also make nightmares more terrifying for people. So there's a number of effects on human behavior and performance. First, the subjective effects. Often these drugs make somebody feel tired or apathetic or weak. At high doses, they can they can cause confusion and impair somebody's comprehension. And then they can also cause nausea. Then some TCAs at least, can have impairment on vigilance tasks. So this is things like requiring memory or attention or concentration. They can cause cognitive impairment, and psychomotor impairment as well. SSRIs and SNRIs might, at least some studies have shown they might improve episodic memory, working memory, mental processing, and motor performance. But then there's also effects on personality, and the book talks about this article from the early 90s, where this psychiatrist, Peter Kramer, called Prozac cosmetic. He came up with this term, cosmetic psychopharmacology, and he claimed that Prozac could provide social confidence. And obviously, this is controversial, to say the least, to the idea that you could use a drug like Prozac, an antidepressant, to mask an aspect of personality that you'd like to change. But this has been noted that it can provide social confidence, or kind of mask anxiety or compulsive behaviors, things like that. And then finally, the effects on treating depression. This is actually the efficacy of the drugs. This is why people take the drugs. So the antidepressants are similar across the classes of antidepressants in terms of their efficacy. They're all in the general population, these drugs have similar levels of efficacy. However, there are individual differences as to which class is the most effective. That's probably due to the fact that there can be different mechanisms of depression. Basically, different people might have different neurochemistry or neurophysiology that is contributing to their depression. So then different classes work better. The severity of depression also affects how well these drugs work. And then some types of depression respond better to some classes too. And then another big point here is not just the efficacy, but also the side effects. The side effects of these drugs vary from person to person, so that's a big reason why people might want to switch from one drug to another. So 60 to 70%, about 2/3 of people with major depression do get relief of their symptoms from medications. And not quite half, the book says 28 to 50%, show full remission of symptoms with these medications. However, the placebo response rates are as high as 30%, so almost 1/3 of people are getting relief from symptoms by taking no antidepressant at all. They're taking placebo, and we've talked about this already. The placebo response rates are known to be very high with antidepressants, and we've talked about the expectancy effect, and it makes sense, but it can be quite controversial. People are spending lots of money on these medications, and the money's going to pharmaceutical companies. So why pad the pockets of the pharmaceutical companies on these drugs that really don't work all that well? So it's a pretty high placebo response rate, 30%, especially compared to the overall response rate at 60 or 70%. So basically the idea is that the placebo is, at least about half as good as the medication itself. And then there's another point here on an active placebo. For TCA, they can provide an active placebo where a drug produces side effects of the TCAs, but obviously it's not a TCA, so it's not treating symptoms. But because of those side effects, people believe that they're getting an active drug. And so that's an interesting point, that you can actually have an active placebo that produces the side effects of the drug, and therefore the expectancy effect is just huge with those placebos. So it's unclear if tolerance develops to these drugs. At least anecdotally, some people do require increasing doses, but it's not well established in the research that tolerance develops to the drugs. It's not statistically significant that people develop tolerance to these drugs over time. However, tolerance does develop to many of the side effects. So nausea, the headaches, many of the side effects subside with time. However, tolerance does not develop to the sleepiness that SSRIs cause, and so people who experience this side effect will continue to have it in general. So there's some general symptoms of withdrawal across these classes of antidepressants. Restlessness, anxiety, chills, muscle aches. Akathisia is basically it's restlessness, or the book describes it as a compulsion to move. These different side effects might occur upon sudden discontinuation. And then there's also specific symptoms for specific classes of drugs. SNRIs, SSRIs, I've listed a bunch of them, and I don't need to read them to you. Instead of withdrawal from antidepressants, these symptoms are also often called discontinuation syndrome. So you use the phrase discontinuation syndrome to refer to basically withdrawal symptoms when discontinuing an antidepressant. And because of these symptoms, generally it's best for patients to consult a doctor to get off of their antidepressants rather than just discontinue their own medications. So TCAs and MAOIs are not reinforcing with self-administration patterns. When people are given the option to take these drugs, generally people can take it or leave it, and same with animal studies. SSRIs and so second and third generation drugs have been known to treat addiction to other drugs, specifically alcohol and nicotine. So specifically mentioned here is bupropion, where Wellbutrin is its brand name as an antidepressant, and Zyban is its brand name as a smoking cessation aid. And then for compliance, generally because of their side effects, any drug that has less side effects is going to be the best for compliance. Because depression is a chronic disorder, people need to take their drugs on a regular basis, and so then the drug that provides the best side effect profile is going to be what is best for compliance. So SSRIs have a lot better side effect profile than TCAs and MAOIs for most people, so that's why they're better for compliance. We've talked a lot about the side effects of these drugs. There's additional harmful effects on reproduction that are listed here. All different classes of antidepressants can have harmful effects on reproduction. And then violence and suicide. There's a warning label on SSRIs after the FDA reviewed clinical data in 2004. They found that especially young people, children and adolescents, were at an increased risk of violence and suicidality. It's 4% of people on Prozac versus 2% on the placebo, so it's still quite rare, but it was increased and it's obviously very serious. So they gave it a black box warning, which is the most serious type of warning to put on a pharmaceutical label. In 2007, that warning was extended up to young adults, up to age 24. So again, this doesn't happen with everyone. In fact, only 4% of people in the clinical trial. So it's not common, but it's been observed in at least some people. It's also possible to overdose on these drugs. Tricyclics affect how the heart muscle contracts. So they also have a therapeutic index that's fairly low, 10 or 15. And so it's easy enough to overdose on those, and it affects how the heart muscle contracts, and that's why you would overdose. MAOIs have been linked to high death rates. Remember the problem with tyramine metabolism. So people on MAOIs who don't watch their diet can overdose in that way. And then serotonin syndrome. If there's too much serotonin flooding your nervous system, it can cause kind of more nuisance problems like disorientation and agitation and confusion, but it can also dysregulate other autonomic nervous system functions. So it can cause high blood pressure, irregular heartbeat, which can lead to shock and then even coma and death. SSRIs and SNRIs are considerably safer than TCAs and MAOIs, even though they work on serotonin levels, serotonin releasing neurons, and serotonin receptors. They can lead to serotonin syndrome, but they're considerably safer than the other classes. There's a number of other treatments for depression besides just the pharmacological antidepressants that we've talked about for the last 15 slides or whatever. So if a person's taking antidepressants and they're not working, or they've tried different classes and haven't found relief of their symptoms, there's other options for them. So there's several herbal remedies that have been shown to be effective. Things like St. John's wort, lavender, saffron stigma. There's a number of herbal remedies that have been shown to be effective. Electroconvulsive therapy is becoming more acceptable again. It's relatively safe. They use muscle relaxers or tranquilizers, so it's not painful if the patient's anesthetized. And basically, an electrical current is sent through the brain to stimulate a seizure. And the theory is that it's like hitting the reset button on the brain. It's like shocking your heart with a defibrillator. One negative side effect of this is that there is memory impairment, especially of the time when the person is going through ECT. But it does work well. Then deep brain stimulation. These three are all basically stimulating the brain, trying to treat depression. Deep brain stimulation is where electrodes are chronically implanted in the prefrontal cortex. You can think of that being like a pacemaker for the brain. Transcranial magnetic stimulation, again, it's stimulating the brain but without an electric current. It's instead of an electric current in ECT, it's using a magnetic field to stimulate the brain. The book mentions exercise for mild to moderate depression as well. And then there's a number of different therapies that can be used. So cognitive behavioral therapy is considered the gold standard of therapy, at least in research. But there's a bunch of other types of therapies that can help people focus on solutions rather than dwelling on the problem, or become more mindful, or what have you, with different types of therapy.